Thank you very much for having me here to talk about suspicion and diagnosis of lymphoma. And I apologize, I have a bit of a raspy voice today. Hopefully it lasts. Okay, so I have participated in advisory boards for a number of companies, as you can see on this slide. As I'm not talking about any therapeutics in this talk, I don't think there's anything applicable. With respect to my objectives, the main objective is to review the N60 lymphoma pathway because I think it nicely illustrates a diagnostic approach to patients, and also to discuss risk factors for lymphomas, as well as describe some common clinical presentations. And I will also highlight the role of different imaging modalities as well as diagnostic procedures in the diagnosis of lymphoma. So just as a little bit of background, lymphoma is very common. It's the 5th most common cancer in Canada. There's about 300 Manitobans diagnosed with lymphoma each year. That's not including CLL. And what we know about diagnosis of lymphoma is that it, no matter what country this is studied in, it seems to take longer than most other cancers that are studied. And I'll sort of highlight why that is in later slides. With respect to primary care, just to give you an idea, because this is fairly common, most primary care practitioners will diagnose one non-Hodgkin lymphoma every couple of years and one Hodgkin lymphoma in their career. So just as a very simple classification, I think some of my colleagues are going over this again. So broadly, this is how we split lymphoma. And Hodgkin's is generally separate because it has separate clinical characteristics as well as pathological characteristics. It's important to note that it's actually a small portion overall, so about 30 patients per year in Manitoba diagnosed with Hodgkin's. Of the non-Hodgkin's lymphoma, by and large, we're talking about B-cell malignancies here. T-cell malignancies are very, very rare, and they can often be very hard to diagnose. And so I'm concentrating really on the more common types of lymphoma. We also broadly separate into indolent, which means slow growing, with a continuous risk of relapse. So non-curable, but often people live very long with their disease. It's more like a chronic illness. Aggressive lymphomas, which are generally curable, and the very high-grade lymphomas, with some examples of the most common subtypes that fall in those categories below. And so I have a case here, and just to discuss some of the risk factors, and just want to draw your attention to if I'm reviewing this case, which I did as a referral, what comes to my attention. So this patient has a mass, and the radiologist felt it was likely lymphoma. What really comes to my attention in this consult is what's circled in yellow, so the history of rheumatoid arthritis as well as the history of methotrexate. We'll talk about why that is. So with respect to suspicion of lymphoma, the Canadian lifetime probability of lymphoma is 2%, and this is slightly higher in men compared to women. For almost every subtype of lymphoma, this also remains true. There is multiple risk factors that have been established, but most of them are actually weak. So things that people commonly think of, age, male gender, environmental things, those are very weak risk factors, meaning they don't raise your chance of lymphoma that much. In terms of things that greatly increase the risk, what falls into this category mostly is immune dysfunction and immune disorders. So primary immune disorders, so congenital things that people are born with, the lifetime incidence of lymphoma is very, very high in these patients. Also, more commonly is patients with secondary immune disorders. so that have autoimmune disease with or without immunosuppressants, as well as organ transplants, HIV, and other conditions that require drugs that modulate the immune system. And so just to talk a little bit about family history, because this is a very common question. So just again, to put it back into perspective, if the lifetime probability is 2%, when we look at familial studies, what we see is that that for non-Hodgkin lymphoma, the increased risk is about 1.7-fold with first-degree family members. If we look at other specific subtypes of lymphoma like Hodgkin's and CLL, you see the increased risk written down there. When you calculate it out, what that means is that for non-Hodgkin lymphoma overall, with a first-degree family member, the risk really only changes from 2% to 3.4%. When you look at subtypes that are even less common to start off with, even with the increased risk because of family history, the risk is still very, very low and not that much different than the general population. So this is what I usually tell patients to reassure them about their children, etc. And I also let them know that there really is no role of screening in family members because of this. And there's also no screening test for lymphoma. Okay, so this is the In60 pathway, and I believe you have copies provided to you as well. Some of you may have already seen this, as it's been on the Cancer Care website for over a year now, but I'd like to walk you through it because I think it's a useful tool for going through some of the common presentations of lymphoma. And so I just want to start off by pointing out some of the features. So in the top left-hand corner, I've highlighted those risk factors that really increase the risk of lymphoma. And that doesn't mean if they're not present, a person can't have lymphoma, but patients that have immune deficiency or a prior history of lymphoma would obviously be a high risk, and especially for those subtypes that we know tend to come back, like indolent lymphomas. We're going to go through more of this diagnostic pathway in a minute, so I'm just going to move on for now. Okay, so just to talk a little bit more, so we know that people can tend to have a number of visits to primary care before investigations or referral. And I think that this is not because, I think this is really because there's no symptom signatures for lymphoma. People can present so variably. They can seem very well, or they can seem very sick, but it can seem very much like something else. So it can mimic infections or autoimmune disorders, etc. And so we're going to talk about some of the more common presentations. So when we look at symptoms or signs on exam or in blood work, the most predictive thing is abnormal lymphadenopathy. And it's important to note that this may also be found incidentally in a very high number of cases. We're going to talk a bit more about abnormal lymphadenopathy in coming slides. So people often think of B symptoms, so the sweats, the weight loss, etc. But what's important to know is that in isolation, this really does not increase your likelihood of lymphoma or rule it out very effectively. So going back to the abnormal lymphadenopathy, so in a primary care practice, most of the lymphadenopathy that's seen is going to be benign. So what makes a lymph node suspicious? So really it's the size of the lymph node as well as persistence with the absence of an obvious cause. So there's no dental infection to explain it, or no ear, nose, and throat symptoms, for example. So really it's the clinical context that has to be put together. Aside from lymphadenopathy, the most clinical symptoms and signs as a single feature are not very helpful. But when you combine abnormal lymphadenopathy with certain things like weight loss, abdominal complaints, shortness of breath, high white count, abnormal blood work basically, as you see, that really increases the likelihood of lymphoma. And so this is your basic approach to when you have a patient present with an abnormal lymph node, basically a complete history and physical exam. I've highlighted at the bottom some of the initial tests that should be taken, so CBC, chest x-ray, HIV tests. I think it's important not to forget it. We put it very early on in this pathway. And if there is a suspicion, so if you have some red flags raised, then to move on with a CT scan, because this is the imaging of choice, so not ultrasound. So here's another case of a 19-year-old, quite well, although she has a node in her neck, and it's above it's bordering on a size where it could be normal or benign, could be abnormal. She's otherwise completely well. She has no symptoms. You find nothing else on exam. Her blood work is 100% normal. So what do you do with this patient? I think the algorithm tries to address this. So with this patient, you could observe for a short interval. If it remains, then you need to proceed with further workup. What this practitioner did was a chest x-ray and found this. And this is the signal. So you see the lymphadenopathy within the chest there. And that is a signal that you need to proceed with workup now because this is obviously not a benign lymph node. This patient ended up having a limited stage Hodgkin's disease and was cured of her disease. Okay, so these are the red flags, and they're highlighted in the box on the pathway as well, but I just wanted to bring them out to you and show them on their own. So if you have abnormal lymphadenopathy in the high-risk patient, that should be a red flag. Additionally, if you have abnormal lymphadenopathy in combination with abnormal blood work, their lymph nodes are widespread, bulky, there's splenomegaly or B symptoms that go along with it, they're rapidly growing, or the patient's very symptomatic from the lymph nodes, meaning there's a whole bunch of intra-abdominal lymph nodes and they have abdominal pain, bloating, then these should be red flags. So going back to the algorithm, on the left-hand side, you can see that we started off the algorithm with the two scenarios of either palpable lymphadenopathy or lymphadenopathy that's found on imaging, recognizing that lymphadenopathy found on imaging itself has a wide differential diagnosis. In either patient, the next step is the history and physical exam, and as you see in the top left-hand corner, we've highlighted to consider the differential diagnosis. Really, this is a big job. You have to consider infection, other malignancies as you're working through things with this patient. So after the history and physical exam, CBC, chest x-ray, so the initial workup, one thing I want to highlight is if the lymphocyte count is elevated, then this may mean that it's going to be more straightforward to diagnose the patient because the peripheral blood can be sent for flow cytometry to rule out lymphoma. And what you might find here is CLL or perhaps an alternative lymphoma, and then the patient can simply be referred to Cancer Care Manitoba. If there is no increase in lymphocyte count in the peripheral blood flow is not going to help you. The next thing to do is to consider, does the patient have any of those red box features that we discussed? If they do, then the next step should be proceeded to in terms of diagnostic workup, and we'll go over that more on the next slide. If not, they can be followed for a time interval. The literature is variable in what it suggests, and we decided on 4 weeks when coming up with this algorithm. So just a moment before we talk about the next page, which is how to determine the next best step for patients, I wanted to highlight a couple of the different diagnostic tests. So the diagnosis in most patients is made by lymph node biopsy or biopsy of an abnormal mass. FNA, the role really in lymphoma is to rule out other cancers. It sometimes will tell you that there's a lymphoma, but it can also come back for being reported as normal, and the patient can still have lymphoma. So an open biopsy or a core biopsy for patients where there's no palpable superficial nodes is required. And just as a note, this should be sent lymphoma protocol because it gets to the pathologists that ultimately sign out the lymph node biopsies much quicker that way. So the second page of the algorithm is a diagnostic pathway algorithm. So this is a patient where you've decided, okay, we need to move on, we need to investigate because I'm suspicious This may be lymphoma or perhaps another malignancy. In the box on the far left, it basically highlights that if there's a palpable lump, then what you need to do is you need to send that patient to a surgeon. And we know that it's a bit variable what type of surgeon these patients go to depending on where you live in the province and where the lymph node is. So for example, in the neck, it may go to a head and neck surgeon, but for axillary inguinal lymph nodes, a general surgeon is a good choice. We highlight to please order CTs at this point. You don't have to wait for them before you send this patient to the surgeon, but it's a good idea to order them. What the preferred site of biopsy is going to be always the palpable lymph node first, because we can get a bigger piece of tissue, followed by the mediastinum, followed by a CT-guided biopsy if necessary. The algorithm then points, one of the things I also want to point out is if you get preliminary results that tell you that this is lymphoma, please pass on the consult at that point. You know, we don't need a final pathology report, and that helps us get things moving for the patient. All right, so this is our timeline model, and it basically, I just put it here because we know that at this point that all of the patients with aggressive lymphoma, which is what we're targeting, do not move from suspicion to diagnosis to treatment in 60 days, but we're hoping that that could be our target for some point in the future. For that to happen, as you see, things really need to happen simultaneously. So while the patient's getting their lymph node biopsy, the CTs have to be ordered. While the final pathology report is, you know, awaited for patients where it's very highly likely they have lymphoma, hopefully we're already booking them into our clinic to see them. And because that's really the only way that this is practical. Things cannot happen sequentially and have it and fit in that same type of timeline model. So my take-home message is, while the algorithm makes it seem straightforward, there really is no one presentation of lymphoma. But it's the patients with the abnormal lymphadenopathies, so more than a couple of centimeters persistent, that need investigation. There's a lot of factors that go into kind of, you know, whether you pursue investigation for lymphoma or infection. And so if you're confused as to what to do next, please give us a call. If there's red flags, proceed without delay, and please use the clinical pathway developed. Thank you.